must make timely decisions on whether products, especially tobacco harm reduction products, can be allowed for sale or not. However, stakeholder groups with pending pre-market tobacco product applications, or PMTAs, have been waiting for several years to a decision which far exceeds the 180-day review period written into law. Can you tell me in 25 words or less, why has the CTP failed to comply with the statutory review period despite the fact that the CTP's staff has more than doubled in the last decade?
You said less than 25 words. It's 26+ million applications. We're now 99% done, and soon we will be within that time frame.
But you know, among those applications are very frivolous applications, and there's like a couple of dozen in there that are coming from legitimate places. And you all should have focused your attention on those. It's hard to believe that an agency that's doubled its staff over a decade to over 1,200, receives over $700 million per year in funding, is still not meeting the deadline for these PMTAs, the serious ones again. It's my understanding relatively few serious from legitimate companies. What steps are needed to bring more accountability to the CTP?
I'd remind you that the vaping industry right now pays no user fees, so all the money and people that are hired off of the combustible product industry. There we have tremendous gains. So in terms of the transparency now of the applications, people can track it. The information is published, and you're seeing continuous improvement in our efficiency.
So what are the performance metrics does the CTP have to ensure they're being good stewards of the tobacco user fees?
It's the numbers of applications, the time it takes to review them, the outcomes of the reviews are discussed by numerous watchdog groups that are looking at everything that we do.
Had the CTP done its job over the last decade, there should have been tobacco harm reduction products approved through the appropriate process. There's clearly a demand for these products that's being filled by illicit flavored disposable e-cigarettes, now make up more than 70% of the e-cigarettes or ends market, as my colleague is talking about, most of which are from China. What is the FDA doing to rectify this problem of illicit products in the market?
If I may, tobacco harm reduction product is an industry term. I'd say we're all in favor of reducing harm from tobacco. And as I went over with an earlier question, we have an increasing number of warning letters, civil money penalties, and injunctions now, and seizures now at ports of places of import. It is a very large number of products. There's no question about it. It is a big job, and we have a lot more work to do.
Commissioner, you've recognized the critical need for the public to have access to accurate medical and scientific information to help inform the decisions they make about their health. How does the FDA justify the decision to spend millions on ad campaigns and scare tactics such as brain worms or metal dragons that are not based on verifiable facts? And when will the FDA focus on the facts about what can make cigarettes deadly, as Congress intended in the Tobacco Control Act, instead of relying on misunderstandings and outdated narratives?
I'm not sure I follow that question. I would just say we've seen dramatic progress in reduction in combustible tobacco use, significant reduction in the number of people dying, although it's still 460,000. I'll just note that in my time at Alphabet, I learned a lot about advertising. I think our statements are based in fact, and they include a component to reach into the culture of people that need to receive the information. Simply stating a fact when you're talking to a teenager is not necessarily the best way to reach that teenager. You need to have the mind prepared to absorb the information.
So brain worms and metal dragons.
I don't know about brain worms and metal dragons, but I'll take your word that something alluding to that must exist somewhere in there.
Thank you, Mr. Chairman. I yield back.
Gentlelady yields back. Chair recognizes Mr. Khanna from California for 5 minutes.
Thank you, Mr. Chair. Commissioner Califf, thank you for your service. So many Americans are frustrated that even with insurance, they're having to pay thousands of dollars for drugs for cancer, for multiple sclerosis, for getting inhalers, hundreds of dollars. I want you to help explain to the American people why this is happening, and to start by giving 2 sentences on what the FDA's Orange Book is.
Well, the Orange Book is a listing of patents that are relevant to drugs that are marketed.
Correct. And if something is listed on the Orange Book, is it correct that for 30 days, for 30 months, a generic manufacturer can't produce that?
That's with some caveats, but essentially that's a fair statement.
So let's take a couple examples. You have a multiple sclerosis drug, Copaxone, produced by Teva. It costs patients between $3,000 and $50,000, and it is currently listed on this Orange Book. Now, Teva, the company producing it, is going to come to have it listed with no real changes to the drug, cosmetic changes. If they list it again, then no generic manufactured drugs can be produced, correct, for 30 months?
It's a little more complicated than that. I mean, you left out one step before that, which is that you have to have a patent, which says it's a significant new thing.
But
our role in the Orange Book is ministerial. That is, we list the
but you have discretion of whether to list it or not, correct?
Not much discretion.
But technically, you have that discretion.
Not really. We have to list them, and
What would happen if you didn't list them?
we'd get sued.
But what is happening is you have these companies that are getting you to list this and not have generic competition. And so then, as a result of it, the American people are paying $50,000 for drugs on multiple sclerosis, or in the case of Revlimid for leukemia, they're paying $17,000 because you're listing something in the FDA that isn't allowing generic competition. Now, you can say the blame is with the patent office, but if those were not listed at the FDA, you'd have generic alternatives. Is that not correct?
You know, my grandfather was a Baptist minister. We are all sinners, so we'll take our share of blame here. It's a point of emphasis between us and the patent office now to try to get rid of frivolous patents, which is what you're referring to. Frivolous patents just to extend the time period in which a company.
Would you say that in the
profit.
case of Copaxone, where Teva is asking for more patents and multiple sclerosis patients are paying $3,000 to $50,000, that could be frivolous? Or with Revlimid, which is where they have 27 patents to treat leukemia, that there could be some of those being frivolous?
As FDA commissioner, that decision really is an FTC decision. I have personal opinions about parts of this.
What's your personal opinion on those two?
There are too many efforts made to extend patents, but I won't comment on a specific one.
But what about for AstraZeneca and the inhalers?
Well,
with Symbicort?
I can't refer to a specific one. I will note that my mom got some extra life expectancy due to Revlimid, and I'm very familiar with what happened with the costs.
And so my question, I guess, is what can we do in Congress? Because this is what's frustrating people. And I'm not blaming you, sir, but I'm saying that you've got a system where you're listing these drugs. Maybe you're saying your hands are tied. It's not bringing those costs down. And we keep getting, from the American people's perspective, how do we solve this? And if you could give me 10 seconds, I have one more question, but do you have a 10-second recommendation?
Maybe the analogy's worn out. Again, we're the referees, so it may be something where our staff will need to get together with yours and the patent office and see if there's anything that can be done to tighten up the laws here.
And the last question I want to ask, and it's not a gotcha or anything, because I know when you were in the FDA, then afterwards, you got consulting fees from Merck, AstraZeneca, Biogen. I take you at your word that there were ethics reviews, and then you said that there were no ethical conflicts. But one of the things I proposed is members of Congress should not become lobbyists. Would you commit today that after your service as FDA chair, you will not take any money as consulting fees from Big Pharma going forward?
I have a written record on this for 2 years. Beyond that point, we'll have to see. I'll be
Well, why not
70.
just make that commitment so that the American people have confidence that you won't take, you can make plenty of money at Google or somewhere else. Why not just say, I'm not going to take big pharma money?
I'm not looking to make money. I'm looking to contribute to the development of effective.
And why not say you won't take it after regulating it? Just make that commitment today.
I certainly have made the commitment for a period of time, but I can't speak for the rest of my life.
I think you should.
I appreciate your opinion.
Gentlemen, time's expired. Chair recognizes Mr. Fallon from Texas for 5 minutes.
Thank you, Mr. Chairman. I think we have some bipartisan agreement. Representative Khanna, I would love to co-author any bills you have for preventing members of Congress from becoming lobbyists. I think that's good government, so thank you for that. Thank you, Mr. Chairman. And I'm here today, Commissioner, not so much as a member of Congress, but as a parent. And I just wanted to visit with you on a few things. Particularly, I have two teenage boys, 17 and 14, and I see the teenage vaping, skyrocketing. And I think that's an entry to some really nefarious habits moving forward. And I'm particularly concerned about the use of illegal and unregulated Chinese vapes that was touched on before, and the FDA's role in contributing to this, I think, proliferation that we see across the country. So the Tobacco Control Act of 2009 created a pre-market review process allowing for new tobacco products to enter the market. Yet, as myself and nearly 60 of my colleagues pointed out in a letter we sent to the President last month, a letter led by my good friend, Congressman Richard Hudson, despite the FDA's receiving over 26 million smoke-free applications since this law, the FDA has authorized fewer than 50 product applications, with less than 10 being commercially available. During this time, however, they have authorized thousands of combustible cigarette product applications. But as January of 2024, there were only 23 authorized e-cigarette products, and all by 3 manufacturers. The FDA's inability to process the PMTAs in a timely manner has resulted in a proliferation of illegal Chinese vapes flooding the market all over the country to meet the consumer demand, often in flavors that I'm sure you hopefully agree are horrific in so much as they appeal to kids. Peach Mango Watermelon, which is a flavor currently offered by EB Create, a widely popular brand formerly known as Elf Bar. This is a Chinese company whose vapes are illegally here, yet easily purchased at local stores. In fact, local smoke shop over in Virginia, this picture was taken 2 days ago, and you can see in the yellow up there, those are all displayed. They're illegal Chinese vapes along the wall. And we're not speaking about hypotheticals or back alley deals. This is flagrant noncompliance. And this was just randomly discovered. By the inaction of the FDA, what we essentially see is almost a prohibition on legal products, with unregulated and illegal products rushing in to meet the demand. Then, by further weak action on enforcement, U.S. stores have seemingly no concerns about openly selling the products all over the place. So, Commissioner, by law, how long does the FDA have to review PMTAs and take action on them?
I believe it's 180 days is legal.
And you're correct, and how long on average is it actually taking?
It's hard to calculate an actual number. There are 26 point something million applications, and some still outstanding. So, we're obviously not meeting the 180-day timeline, although it's getting better as we're plowing through and 99% complete, which still leaves hundreds of thousands to go.
Do you think the industry stakeholders have told us that they're claiming it's 3 years? Is that feasible?
Remember the history, and when I was commissioner in 2016, it was right when vaping was starting, and it went immediately to millions of products. There were some laws in between, and it's the case that there was such a flood of products. It could be if you went back, 3 or 4 years ago, you'd say, okay, 3 years until now. But if you look at applications coming in now, it's much shorter than that.
Because the FDA's website shows that the approved PMTs for 2023 took roughly 2.5 to 3 years for each one.
There was a bolus effect that had to be dealt with. As one of your representatives already pointed out, millions were taken care of by getting rid of the ones that didn't have useful data in them.
I think that it would behoove you all to have a regulatory framework in place And warning letters are one thing. How many seizures have we had at retail shops across the country?
We've only had a few seizures. We've had 32,100 civil money penalties, and those are ramping up considerably as we go. As I think you know, seizures require a whole different order of magnitude of legal work, both before.
So we only have a few seconds left. So how do we? These are all over the place. So what do you think that the FDA can do to, mitigate this?
Well, given the fact that there's a vape shop in almost every neighborhood, it would take a lot more people to do what you're saying of clearing the shelves. So we have an action plan. It's going to get better and better. As I've already said, if user fees were paid by the vaping industry, that would be about $100 million. We could hire a lot of people and spend a lot more time out there in the shops.
And I'm not trying to suggest that every illegal Chinese vape is going to be taken from the shelves, but you know as well as I that when you can set examples and make examples, and the word gets out that if you have these products, you're going to heavily fine, and they're going to seize them as well. Thank you, Mr. Chair. I yield back.
Gentleman yields back. Chair now recognizes Mr. Mfume from Maryland.
Thank you very much, Mr. Chairman. I want to thank you and Ranking Member Raskin for convening this hearing. And before I go into my observations, Dr. Califf, let me go back to something that the ranking member said earlier that I don't want to get lost in all of this, and that is that maybe what we ought to be doing in addition to this is trying to find a way to create more regulatory pathways, giving the FDA the ability to do many of the things that you said you could not do here today. Dr. Califf, I'm deeply concerned about the overprescribing of ADH medications, particularly Ritalin and Concerta, as it relates to kids in poor neighborhoods as a means of dealing with their, quote, hyperactivity in school, and that so many studies have shown that whether they're poor black, poor white, poor Latino, this overprescription seems to take place. And I'm not a conspiracy theorist. I just don't think Humpty Dumpty fell. I think he was pushed. And so moving under that premise, I think that unless we do have greater regulations over the overprescribing of these medications, it will continue. Now, let me just flip that around to the other side. I'm also deeply concerned about children who are unable to focus on things and are given these medications and where all the protocols have been followed. And I'm concerned about that because in many instances, those drugs, unfortunately, have been part of the shortages. I'm concerned about cancer patients who are forced to delay treatment, as you know, because many of the required medications are out of stock. And so those are just a couple of things that I'm hearing from my constituents in Baltimore on a regular basis. I know that supply chains were disrupted during COVID and that there have been intermittent and sometimes not intermittent drug shortages occurring throughout the U.S. But I would be less than honest if I didn't just tell you from my perch some of the things that I hear. And I recognize you don't carry a magic wand in your back pocket. The only thing you can do is to help guide us, listen to us, and suggest to us ways that we can help you. The FDA serves as an important regulator, to say the least, and it is well positioned to assess potential supply chain disruptions. Can you tell us, and this committee and the people around the country who may be watching these proceedings, how is FDA working now, currently, with manufacturers to mitigate the ongoing drug shortages, and have those manufacturers, in your opinion, been transparent with the FDA about potential shortages and the real root causes of those shortages?
Thank you for that. First of all, just a comment you made about the underprescribing and the overprescribing. I think it exemplifies a major problem that we have in the intersection of the responsibilities of the FDA and the practice of medicine. There is no doubt that people that need these drugs are not getting them and people that don't need them are getting them. And that equilibrium, of course, is not set by the FDA. I'm also a physician. It's a clinical quality issue that we need to work on, and we're trying to help as best we can with that. But your main question about the manufacturers, we work every day with the manufacturers. They're required to give us certain information, but frankly, they've resisted us giving us some of the crucial information that we really need. When there is an impending shortage, we're finding that they're very cooperative to work together to try to fix it. But it'd be better if we had all the data we needed to put together predictive algorithms that would allow us to intervene preemptively much earlier and prevent the shortage. So we have a list that you all have a copy of that lists the areas where the correct information would make a difference. But I also want to point out that while there's a shortage of the stimulants for ADHD, the biggest shortages are occurring in inexpensive generic drugs, where the less expensive the drug, the more likelihood of shortage, because of the way the market is not succeeding in rewarding high-quality manufacturing. And that's a point I think we really need to address over the next few years.
And any guess on your part as to what factors affect non-generic drug shortages?
For non-generic drug shortages, there are really only two major types, because if not a generic drug, as we've already discussed, in general, the manufacturer is making a handsome profit once the product is on the market.
That's my point.
So they're pretty good at figuring out how to make it.
Yeah.
The exception, as I said, is Ozempic or the weight loss drugs, where the demand is just so high they haven't been able to keep up.
Yeah. Thank you very much. Mr. Chairman, I yield back.
Chair now recognizes Mr. Biggs from Arizona for 5 minutes.
Thank you, Mr. Chairman, and thank you, Commissioner Calla, for being here today. The University of Arizona has been engaged in research that would advance pain and addiction research to help combat the opioid crisis. They're looking for ways to expedite known drug candidates through the Phase 2 and Phase 3 trials to take non-addictive pain relief medications to the market. U of A has informed me that they have found, if they can repurpose clinically available medications that have proven to be non-addictive and have also shown to be effective for treating different types of chronic pain, they think they're ready to go forward in these trials. But they also report that there's a need to repurpose some of the medications specific to sex differences, because pain is differentiated based on sex, and that would have an impact on how they develop this drug. So the question is, during the COVID era, FDA was able to expedite clinical trials. Yet U of A tells me that they're struggling to obtain approval for Phase 2 and Phase 3 clinical trials on something that could alleviate chronic pain and help reduce the risk of opioid addiction that we see so rampant in the society today. So I guess my question is, could this be a statutory problem, a regulatory problem, a resource problem? What might we be looking at? And I realize I'm giving you a very specific example, but hoping that you can give us some information.
Well, you know, the way it works at FDA and the drug side is there are user fees that are paid, and we have statutory or agreed upon, passed by Congress every 5 years with the user fees timelines. We're meeting those timelines, which are agreed to between the industry, the FDA, and then put into law by your passing the law. I'm not aware of the particular circumstance you're giving. There is a thing that we say at FDA, in God we trust, all others must bring data. So I'd have to know the specific data coming from University of Arizona to know if there may be some issue that's causing a back and forth that wouldn't fall within the usual timeline. But when that happens, it's very much noted that that's the case. So,
well, we would love the opportunity to present you with additional information, whatever we need to find out what may be the hitch in the get along.
That would be fine.
With that, I'll yield to the chairman.
Thank you for yielding. Commissioner, it's FDA's responsibility to ensure the safety and efficacy of all drugs marketed and sold in the United States, regardless of where the drugs are manufactured. Yet the number of inspections conducted annually has been declining since 2013. At the same time, Chinese and Indian manufacturers have received the most FDA warning letters by far. These violations include contaminated medicines, non-sterile manufacturing, and falsified data. So how is the FDA working to keep foreign manufacturers accountable?
Really appreciate that question. As I've already established, we are doing a major reorganization because I agree with you that we need to pick up the pace of the inspections that we're doing. But again, as I've already said, the first line of defense is the manufacturers themselves. And so here's where modernization of our data systems is important, because the more we can keep up with what's going on, not just in U.S. facilities, but all around the world, the better we're able to target our inspections and to have the frequency that's needed to keep the manufacturer in shape. One of the big areas that we're working on now is India, where we've completely redone our inspectional system, and I've personally gone to India to meet with the Indian government to work on the relationship so that the inspections can proceed. And I believe they are acting in good faith in India right now as one example. So think of it as a layer of data and information that should be constantly coming in now that all manufacturing is digitized. And then the human side, where the inspector actually shows up, the investigator, in the facility, those are being increased, and it's been a major point of emphasis in our reorganization.
So there aren't a lot of bipartisan agreement on controversial issues in this Congress, but one thing I think there's overwhelming bipartisan agreement on is the fact that we need to have more domestic manufacturing of our pharmaceuticals. What can, in your medical opinion, as Commissioner of FDA, what can we do in Congress to encourage an environment where all of our essential, or much more at the very least, of our essential pharmaceutical production is manufactured in the United States?
Well, as one of your colleagues pointed out through the Socratic method of asking the question, I don't think it's a big issue for innovator drugs because that industry doesn't experience much in the way of shortage. But for this generic area, it's an area where we do need to reshore significantly.
But it's a national security issue as well.
Absolutely. Right. And when the raw material is coming from China, it's an issue that we need to take seriously. So, as you know, FDA doesn't deal with the prices and the market per se. I would refer you to the HHS white paper that just came out with a large input from us. And basically, we need to create an economic market situation where the price is fair so that the manufacturer can produce a product but also invest in the technology of manufacturing, and can be done using American labor, which is more expensive than labor in other countries. I'd also say, I'm not talking about 100% reshoring. I don't think we need that, but we need enough of a footprint in the U.S. and in nearby countries that we're assured that if something goes wrong anywhere in the world, we keep this up. 95% of our prescriptions are now generic.
Mm-hmm. And we'll touch on that later. My time's expired. Chair, now recognize Ms. Bush from Missouri for 5 minutes.
Thank you, Mr. Chairman. St. Louis and I are here today, Dr. Califf, to first thank you for the work that the FDA has done to eliminate cumbersome restrictions on mifepristone, one of 2 drugs used for medication abortion. As Ranking Member Raskin mentioned at the top of the hearing, mifepristone is subject to a risk evaluation and mitigation strategy, also known as REMS. During the peak of COVID-19, the FDA suspended enforcement of a REMS requirement that mifepristone be dispensed in person. Due to the success of this trial run, we know that in January 2023, the FDA permanently updated the strategy to remove the in-person dispensing requirement. This has proven that the in-person dispensing requirement was never actually medically necessary. I have a bill called the Protecting Access to Medication Abortion Act, which would assure that mifepristone, 1, does not have an in-person dispensing requirement, 2, allows patients to access prescriptions for mifepristone via telehealth, and 3, authorizes all pharmacies certified to dispense mifepristone to patients to do so via mail. So thank you to the FDA for your commitment to your evidence-based care that serves patients and not politicians. Next, I want to turn to sickle cell, a disease that affects approximately 100,000 people across our country, the majority of whom are Black people, and about 2,000 people across my district. In fact, according to the CDC, 1 out of every 365 black children in the United States are born with sickle cell disease. It cuts at least 20 years from life expectancy. And so as a nurse, I've treated people with sickle cell disease. Patients experience totalizing pain, and it is debilitating. This illness completely takes over your life, and it is heart-wrenching, and we don't speak enough about it. So last year, the FDA issued a groundbreaking approval of the first gene therapy to treat sickle cell disease. And so this new technology is the first time genetic editing has been used to treat any disease. As a result, patients who face excruciating pain and even death from sickle cell disease will now be able to better manage this life-threatening condition. For many who may have been unable to hold steady employment, spend time with friends and family, or otherwise participate in everyday life because of this illness, this is truly life-altering and is life-sustaining. This technology would be impossible without the diligent and the science-driven work of the FDA. So, Dr. Califf, what did the FDA consider when determining the new sickle cell treatment, determining that it is safe and effective?
As I believe you probably know, there were actually two treatments approved, one using gene editing per se and another using a viral vector. And in both cases, human clinical trials were done taking sickle cell patients. As you well know, being a nurse, people with sickle cell disease, even though the genetic issue is essentially the same area of the human genome, the manifestation of the disease is quite different. So what was done in these trials were to take people who were having the worst outcomes, that is many attacks, painful crises, and then doing the gene effort, and then following them after and showing that those crises abated almost completely. It was quite a remarkable result, but in a small group of patients. And so there's a lot yet to learn, but it was important to give access to that treatment to those who would benefit.
Okay, okay. Is there potential for this new treatment to be used to treat other genetic diseases?
It's very exciting, and I alluded to it in my opening comments. You know, I was around for the Human Genome Project, and people for decades said, where's the beef? You know, we put all this money into 3.2 billion base pairs and knowing what they are. Now we're here because thanks to the science, we can go in with molecular scissors and snip out the gene that's causing the problem and put in a new one, or snip out the gene that's causing the problem if we don't need to put in a new one. There are 10,000 rare diseases with no treatment right now. You're talking about parents of children who have terrible outcomes. And so this is such a revolution in terms of therapeutics that we're making major changes within the FDA. But it's got to go further than that because you're aware that the cost of these treatments is quite high. So I think there's going to be a lot for you in Congress to work with the administration on here to figure out, you know, if you're a parent of a child with a rare disease now, there's hope that within a few years we could have an effective treatment. But if we have hundreds to thousands of effective treatments, the environment in which this is done has got to look different than it does right now. I hope that was helpful.
Yes, yes. Chairman, okay, thank you. One last question. How can we ensure that people who require these genetic therapies aren't priced out? Because like you started to allude to. But
well, I can take the easy out and say it's not, you know, it's not, as FDA commissioner on a hearing about FDA, it's definitely not in our remit, but I can assure you there are many discussions going on across HHS where, as you know, for example, in sickle cell disease, the majority of patients are on Medicaid.
right.
Because their medical costs are so high and the difficulty with jobs in a case where you're sick a lot, that we've got to come up with new pricing schemes. And I am, as an academic, a health policy person, but I shouldn't opine on that here at this hearing. I'd be glad to talk with you separately.
Okay, I'll reach out. Thank you. Thank you, Mr. Chairman. I yield back.
Chair now recognizes Mr. Higgins from Louisiana for 5 minutes.
Thank you, Mr. Chairman. Mr. Carroll, thank you.